Thank you so much. I'm happy to be here with your organization and your NICU parents. Today, I would like to help parents navigate what I call the parenting path to oral feeding in the NICU. Although not initially usually on parents' radar when they're first admitted, oral feeding often becomes one of the biggest challenges to families of premature or medically complex infants. And it's really not just about getting nutrition in. It's about starting an experience early on that does provide nutrition and growth, but also is about creating positive experiences that last a lifetime and also create connections with parents. So when we think of feeding our babies, pictures like these usually come to mind. You picture yourself breastfeeding, bottle feeding, or both, and it's a fun, happy experience. When you're admitted to the NICU, the reality of feeding often changes. Depending on where you are during your journey, a feeding might be provided by an IV, a pump, or a tube before you get to breast or bottle. And then, especially with premature infants, once you do start feeding your baby orally, the path can often be slow. And I think this is often what can be very hard for parents. Often your baby gets to this point and medically may have made some big gains and you feel like you're just getting over some humps. But then it can seem like starting all over if feeding doesn't go perfectly smoothly. Our premature or medically complex infants are immature and or not strong enough at times for full oral feedings. Your baby may not wake up for feedings, may not be able to take very much at one time, or even may just have a hard time with the suck, swallow, breathe part of feeding due to its very complex nature. One of these feeding difficulties, as I mentioned, may be because your infant is immature, which is especially true if you have a premature infant, and of course is even more true the more premature your infant is. This picture represents two important aspects that can affect feeding. First, it shows the brain of a full-term infant compared to younger premature infants at different stages. Look at the brain of a 25-week infant and note how much is still not present or developed. The brain at this point is immature. Even at 33 to 34 weeks, when our babies often begin feeding, it still is not as developed as the term infant. The other point I want to make about the brain in the early stages of development, and we'll discuss this more a little later, is that because it is still developing, what we do and how we do it can actually affect how the brain develops. The experiences we create shape the brain. As I mentioned, parents are often not prepared for this aspect of feeding. So our goal in the NICU is to help prepare the infant and the parent about feeding from day one. I have 5 points I'd like to discuss, and this is definitely not all there is, but 5 points I think we can think about today and that parents should know to help their infants through this process. I'm calling it 5 to feeding, 5 things to consider about NICU feeding. These are my 5 points today, which believe me, I could talk for 5 hours on, but for today we'll address these. 1 is feeding begins at birth and positive feeding experiences. 2 is get to know your baby. 3, know your equipment, whether it be breast and or bottle. 4, quality is important. And 5, feeding is for life. Now let's break them up and discuss a little more. So number 1, feeding begins at birth. And in reality, actually before that, because the infant learns about sucking and swallowing some in utero. But since that's out of our control, we'll start at birth. The development of oral feeding is shaped by feeding experiences during the NICU stay. We've talked about the brain and that the infant's brain is being shaped by experiences. So what we do with the baby or to the baby in relation to feeding is what the baby learns about feeding. You see, our brains are full of neurons and connections, and they store information that they receive. Information about the environment, touch, pain, feeding, really everything. So what infants learn about feeding during the stay in the NICU can affect feeding for months or years to come. So our goal then is to provide positive feeding experiences from the beginning and set the baby up for success. From day one, we want to start that feeding relationship. And why do we talk about positive experiences? Well, unfortunately, as many of you know, at times the NICU can have some negative experiences for our infants and parents. While many of the procedures and events that their babies go through are essential to their medical treatment, they can be at times unpleasant. Of course, this is one of the negative examples I'm speaking of. Although this is a procedure that's necessary, it does provide negative information to baby. So our job is to tell the baby and the baby's brain that there are positive experiences in this world as well. Part of creating positive experiences is minimizing negative stimuli. We do that by protecting the infant from bright lights or loud noises or negative smells even. Practically, as a parent, you can be a helper. If you're at the bedside and there is an overhead light on that the nurse or doctor really needs on to do their job, you can take your hand and shield the baby's eyes. Your job as a parent can be to support the baby during procedures. And I do want to mention that when you're not present, our job as nurses, therapists, and other NICU professionals is now very focused on providing that positive, supportive environment for your babies. Most NICUs now are very aware of what we call developmental care and very consciously try to limit those negative experiences and provide positive support when the parent is not able to be present. Two of the most beneficial ways parents can provide positive experiences is through kangaroo care and also by providing comfort or support during painful experiences. There are so many benefits of kangaroo care. The list goes on and could be a whole webinar in itself. And if you haven't yet begun in your unit, please ask your nurse or doctor more about this. I'd like to take a moment here to show you a video from the Center for Pediatric Pain Research about kangaroo care and how parents can make a difference in providing this positive support.
Welcoming a newborn baby into the world is a life-changing moment. There are a lot of things for parents and babies to get used to. Many parents don't realize that this includes pain. Almost every baby in the world undergoes painful medical procedures in the first few hours and days after birth, including medicines that are injected with a needle, and routinely get blood tests as part of regular care. Sick or preterm babies often require up to 9 to 10 painful procedures every day, for weeks. And regardless of how many they have, the experience can negatively affect how a child develops. This early exposure to pain can impact how they feel and react to pain later in life, their attention and learning, and even how their brains grow. But clinicians and researchers are working towards solutions. They found some already. Holding a baby clothed only in a diaper and facing you against your bare chest is known as skin-to-skin contact, or kangaroo care. Ideally, it started 15 minutes before a painful procedure, but even as little as 2 minutes can be beneficial. A blanket or shirt can be worn over top for privacy and comfort, and, if they choose, another loved one can do it too.
You seem so much more relaxed and happy. I don't think that any parent should have to sit by and watch their baby without being able to hold them and be there for them.
There are so many benefits of practicing skin-to-skin care. It lowers how much your baby feels in response to pain. It stabilizes their heart rates and oxygen levels, and helps them recover faster.
It just instantly brings you closer, and it just, is very soothing for the baby and even for myself. We just connect more.
For babies that are older and healthy, complementing skin-to-skin care with breastfeeding 5 minutes before a procedure can also enhance the pain-reducing effect. We've learned that skin-to-skin care is safe, free, and natural, and that anyone can do it, anywhere, throughout a child's first year. We've learned that babies experience less pain, and that it's good for parents too. Parents have less stress, and feel more in control and confident. And while we continue to learn more, there is one thing we know for sure. Parents can make a difference. Talk with your doctor and nurse about using skin-to-skin contact or breastfeeding as a way to relieve baby's pain.
I love this video, and I think it shows that you as parents are just so important. So kangaroo care is not just for pain or comfort, however. Kangaroo care is one of the beginnings to positive oral experiences. Kangaroo care has benefits for getting you and your baby ready for breastfeeding and oral feeding or bottle feeding down the line. Think of all the great information the baby receives when doing kangaroo care. They smell mama, they get warm, they might lick at the breast. So let's take a look now. Here are some more examples of how parents or staff provide positive experiences. On the left is obviously kangaroo care, which we just talked about, but then on the right, the baby is having blood drawn, but this process of swaddling and providing human touch, this containing, provides some support to the baby. You can be the one doing this. Another positive experience you can provide if your NICU has incorporated it is infant massage. Infant massage has many benefits, including reduced length of stay, reduced pain, improved weight gain and better feeding tolerance, improved neurodevelopment, and reduced parental stress and anxiety. While we have all probably given someone a massage in our lifetime, it is a little different in the NICU. For this reason, massage with a premature or hospitalized infant should be initiated by your therapist, nurse, or NICU professional, and then taught to parents. Here's a picture of an infant receiving their massage and loving it, or so it seems. And if your baby isn't ready for infant massage, or your hospital hasn't quite developed it or incorporated it into their unit yet, parents can still provide positive human touch, often called hand hugs. So let's now talk about positive experiences for smell and taste, which are related to feeding, of course. As I mentioned earlier, feeding starts at birth. So we want to give baby information about feeding that's positive. We talked a little about kangaroo care and how that gives the good information we want. Another positive oral experience is colostrum swabbing. This is a method of using your first expressed breast milk to help provide the smell and taste of breast milk, and it also helps get the stomach lining ready for feeding and give immune support. Even just having the baby's hand to his or her mouth can be a positive experience. We can help facilitate having the baby's hand near the mouth, having baby explore and lick his hand, and many times this leads to sucking on the hand. After all, later on, one of the baby's self-soothing tricks is to bring his hands to his mouth and suck to help calm down or to get organized. How about oral care? Cleaning baby's mouth is something that often has to be done, but sometimes can seem negative if not done in a positive way. We can do this in a more positive way if we go slowly, support baby by containing while we do it, or putting our hands on the baby to help provide that support. Maybe even use some breast milk on the cloth or whatever material we're using to do that oral care. What's really important is to think about how we're providing oral care. Another idea that can promote positive smell and taste experiences is to leave the baby with a fabric or fabric doll that has a breast milk scent. The way this usually works is that mom has a piece of clean fabric that the NICU has provided, and she wears it for several hours or overnight so it absorbs her scent. Then she leaves it near baby, often near the face, so that the baby smells mom. Many NICUs also use this as a piece of cloth or of gauze with some breast milk smell during a tube feeding. Some NICUs have guidelines about what type of cloth they allow for infection control reasons, so it's important to talk with your nurse or medical professional about this. Smells can be positive or negative, so we want to encourage and consider positive scents. Limit perfumes or strong smells in the NICU. I also often encourage staff and parents when using hand sanitizer to shake your hands and dry them off after you used it, to give it a few seconds before going into the isolette so the baby doesn't get a big whiff of that hand sanitizer smell. And last on my list today, but of course not last, is non-nutritive breastfeeding. Before breastfeeding for nutrition begins, and when NICUs initiate this really depends on the unit because everybody is a little different, but it's common around 31 or 32 weeks, some earlier. We like baby to begin to nuzzle at the breast. This is when mom usually pumps first and then puts baby at the breast to lick and maybe latch a little and do some practice sucking. The purpose is really just to get experience at the breast without having to do all the work of drinking milk, but to just enjoy the experience and learn some good skills along the way. This often occurs at the same time the infant is receiving his NG feeding, so the baby associates some oral experience with the tummy being full. If you are not a parent who is planning to breastfeed, this can also be a good time to offer the pacifier to practice non-nutritive sucking during an NG feed. And of course, this is something that dad can do as well when it's the non-nutritive sucking on a pacifier. Here are some examples of some of the positive experiences we discussed. Of course, there's kangaroo care. And then the bottom picture is an example of oral swabbing or providing some little milk drops. And then this picture here is an example of one of the types of cloths, a cloth doll that is used to provide mom scent. Okay, so number 2 in my 5 to feeding is get to know your baby. Now this may seem simple, and of course as parents we do this, but specifically I mean a few things. First, just your presence in the NICU is key. Research shows that the more you're there, the better your baby will do, and the better you will do actually. There have also been studies that show the more parents are involved, the babies have improved outcomes. So when you change diapers, take temperatures, care for your babies, in addition to kangaroo care and holding, you make a difference. So I know that this creates a struggle. What if you can't be there, right? You might be asking, well, I can't be there all the time. I have, other children at home. I have to work during this time. Not all parents can spend 24 hours a day at the NICU. But when you are there, let's try to make the time useful. Sometimes it takes a little bit of time to get comfortable, especially in the beginning, but actually doing those cares can help your baby. Also, a practical suggestion to help communication might be, if your hospital doesn't already do it, maybe start a journal at the bedside where you and staff can communicate to each other. I know that at many hospitals, the parent support groups help with a lot of great ideas such as this. So communication, that brings me to getting to know your baby and learning about cues. Cues are an infant's way of communicating his behavior. Before babies develop words, they use their body, their face, their voice. And in the NICU, we also pay attention to physiological things like heart rate and breathing. Cues are the way babies tell us how they feel. They also provide us with information on what is or isn't working when we interact with them. Cues can tell us whether your baby is coping with the environment or whether there's too much information and too much going on. Cues can be what we call approach or engagement, you may have heard. This is how the baby tells us what they like and what we can continue. Disengagement or avoid cues tell us what they do not like when they need a break. Our job in the NICU and your job as parent is to read those cues and respond to them. Parents are very good at this. Now, of course, some of these cues might be strong. For example, if the nurse is suctioning your baby, he may cry or extend his legs stiff. But some can also be very subtle. You might just see a little grimace when someone talks too loudly in the room. But you can also see something positive when your baby becomes very calm when you're talking to her. And if she was breathing fast, her breathing might become more regular. This would be a cue that she likes that behavior. Watch your baby and learn these cues. Ask yourself questions. What do you think she's trying to tell me when she does that? I also highly encourage parents to learn very early on about their baby's breathing. Even before feeding begins, feeding full-term infants seems effortless, but our premature babies have more immature breathing patterns that affect feeding. When you hold your baby, feel how your baby breathes. Just sit there and feel. Put your hand on the back. Watch his face, pay attention to the rhythm. When you know what your baby's typical breathing pattern is, then when your baby starts to feed, you will be better able to tell when that breathing pattern is interrupted. This is another area where your infant's feeding specialist or nurse can help you learn about breathing. Of course, babies show feeding cues as well. Feeding cues can be broken up into cues that show readiness, quality, or disengagement, or another word maybe I'm done cues. Readiness cues, of course, tell us when the baby's ready to eat. We watch for signs that baby's ready and stable enough to eat. This baby here has her hands to her mouth, eyes open, and looks like she's getting ready to suck on her hand. Quality cues tell us how the infant is feeding and what we might need to do to support baby. For example, if the baby is bottle feeding and starts gulping, gulping is the cue that tells us the flow of liquid might be too fast and we might need to do something and help support the baby. Your feeding therapist or nurse will help you learn all about quality cues and the strategies to support your baby. And then we have disengagement cues. These are cues that tell us when baby is done feeding. What is really important for us to remember is that, especially at the beginning, this may be after only 5 cc's. We need to respect when baby tells us, "I'm done." Otherwise, feeding a baby when he's already told us he's done can lead to a negative feeding experience. This is key. If the infant is showing that they are done, we stop. This top left picture shows a baby who's definitely telling us something. And without the context, it's difficult to say exactly what. But we can clearly see this baby's quality has been affected and we need to change something or do something different. And the bottom picture, the baby's telling us he's too tired. He's falling asleep, he doesn't really have a latch on the nipple, and we should stop this feeding. I've always tried to teach parents and nurses to ask themselves, if the baby could talk, what would he say? Would he say, "Wow, this is great. I love feeding. I can't wait to eat again in 3 hours." Or would he say, "This is too fast. Please stop. I need a break." Feeding is like a dance. It's a relationship. We present something to the baby responds, and we keep going or we adjust what we're doing. Thankfully, NICUs are moving towards cue-based feeding, where staff are learning more and more about these relationships and teaching parents. Studies have shown that using a cue-based feeding increases confidence of parents and results in improved outcomes for babies. One example of a model of learning about how your infant is communicating to you is the Infant-Driven Feeding Program, or we call it IDF. IDF is an online learning program for all NICU staff that focuses on providing positive feeding experiences from the beginning. IDF isn't just about feeding, it includes information about the brain and sensory development from the beginning, so it includes some developmental aspects, culture change, and incorporating parents. Infant-driven feeding is safe, nurturing, pleasurable, and individually developmentally appropriate. It teaches hospitals how to change their feeding culture and provide consistency of care surrounding feeding. This is really important for parents, since when a program like IDF is used by a hospital, all staff receive the same information, which means parents learn the same information from all staff. Historically, I know it's been frustrating for parents when one medical professional tells them something about feeding, but another person might tell them something else because we've learned it differently throughout the years. An IDF or a strong cue-based feeding program keeps everyone on the same page. One of the most important aspects of IDF is that it is for breast and bottle. It teaches about feeding in general, and it actually has been shown to increase breastfeeding rates. At this time, I'd like to give you a real-life story of how learning this cue-based infant-driven feeding helps parents. I've invited a former NICU mom to join us today who has been a participant in infant-driven feeding. Summer is our guest, and she and her infants spent time in a NICU where they implemented IDF. Summer has been married for almost 14 years and is a mom of 4, a 9-year-old daughter and 4-year-old triplets, 1 boy and 2 girls. The triplets were born at 30 weeks due to premature labor. They spent 37, 37, and 77 days in a NICU in Virginia. Now Summer works as a consultant and also volunteers her time supporting families who are currently in the NICU. Welcome, Summer.
Thank you so much.
Thank you so much for being here today. So I just want to ask you a few questions about your experience with cue-based infant-driven feeding.
Wonderful.
So my first question is, how do you think infant-driven feeding helped you in your feeding journey with your infants?
From the start, there was a focus on our involvement with our infants' feedings. In the beginning of our feeding journey, we participated by doing hand hugs in their isolettes, then skin to skin during tube feedings. Overall, IDF helped us know our infants better. It taught us how to watch for their cues before, during, and after feedings. As a person who loves schedules, I had to learn to be a little bit more flexible and adapt depending on what each of my infants needed.
Thank you. And I love how you just said depending on what each of your infants needed, because that just shows that it's so important how we look at each baby differently. And it's not, infant-driven feeding isn't a recipe, but we're looking at every baby individually. So thank you for that comment.
Absolutely.
Here's a big one we get about cue-based feeding or infant-driven feeding. Did IDF help you with breastfeeding? And then yes or no, kind of talk a little bit about that.
Okay, so yes, absolutely. IDF did help me with breastfeeding. Again, I had triplets in the NICU. And so because we had 3, I had initially planned to only pump and bottle feed the babies. But when 2 of my triplets were ready to begin oral feedings, our nurses and lactation consultants explained the basics of IDF and then also protected breastfeeding. They encouraged me to try breastfeeding and were there to help me with each step. So it took a lot of adjustments, but it ended up being successful. And I think that if I had done that from home, or if they had tried to encourage me not to try, then I likely would not have done it. But IDF set us up for success, and I'm so grateful that I was able to have those more intimate moments with my babies through breastfeeding.
That's great. Thank you. I think that we've heard a lot of people might say that sometimes cue-based feeding or NICUs are more bottle feeding, but your story really supports the fact that learning about cues is learning about cues. And it doesn't mean just a bottle or just the breast, but it's about learning about feeding in general and responding to your baby. So that's great. What about do you think IDF and cue-based feeding are just for the hospital, or do you continue to use these concepts of infant-driven feeding when you're transition home?
So for us, we absolutely use the concepts when we transitioned home. I think that's one of the things that I love so much about IDF is that it just felt so natural and it made our transition home so smooth. Our son, the oldest of our triplets, was our most challenging NICU baby. He was on oxygen for an extended period of time, as well as had a history of aspirating. And in the NICU, we learned to watch for a pattern of suck, swallow, breathe as he fed. We also learned how to pace his feedings and hold him in a way that kept him from aspirating. We were able to continue each of these when we got home and truly believe that he was able to learn to eat with more success because of this.
Great points. You're right. Learning about feeding lasts for a very long time. It transitions from watching your baby at the breast, at the bottle, but in the high chair when he maybe does a simple little, negative, I don't want that, but it's about learning about those cues and how to respond for a lifetime. So thank you. And I just have one final question to see for our audience. What advice might you have for parents in the NICU in general in feeding their infants?
My biggest piece of advice would be to take a few deep breaths and remember to take it one step at a time. Sometimes those steps might be a few forward, a few backwards, but then you'll move forward again. NICU life is a roller coaster for sure, and there's definitely many unpredictable turns. And the most important thing that you can do and we can do for our babies is to just be there and be present as much as possible. Focus on loving them and figuring out the feeding and breathing is just part of that. The NICU is an extremely supportive place where everyone's goal is to see you and your baby home and thriving.
Thank you, Summer, for that great information and great advice for our parents. I would like to now just say thank you to Summer for not only being here today, but also in her continued work with families, and that she is now helping families after her NICU experience, and she's sharing that with families in so many ways. So thank you, Summer.
Absolutely. Thank you so much, Lisa.
Okay, let's get to number 3. I call this Know Your Equipment, which I've broken up into breast and bottle. For breastfeeding, this involves first to start pumping early as soon after delivery as possible. I know many mothers may have circumstances which prevent this at first, but as soon as you're able to, do so. Pumping often is important since pumping regularly will help with breast milk supply, and breast milk in the NICU has many beneficial qualities. I know these are things that you're encouraged by NICU staff all the time, and you get a lot of information about this. But I also want to encourage you to know about your equipment. How do your breasts early on? I want you to know about that to prepare you for when you begin to breastfeed. Then this information about you and your supply will be so helpful later on, and will give you confidence, and give staff confidence in breastfeeding your baby. For example, how much do you usually get when you pump? When your breast is empty, or, so we say empty, or at least mostly empty, what does it feel like? Do you know what that feels like? Does one side usually have more milk than the other? Do you usually have heavy, fast letdowns? These types of questions are so important when you go to breastfeed your baby, because as a feeding specialist, I really appreciate this information from mom. I've used this information in a scenario where, for example, a mom has a great supply and baby goes to breast and nurses for 20 minutes, but of course we can't exactly tell exactly how much baby got, and we aren't doing a test weight for some reason at this feeding. Well, it can be helpful if mom knows about her supply, because if she usually pumps 60 cc's from one breast, for example, and after the feeding she says she felt full beforehand and now it feels empty, like a full pumping does, and I also heard baby swallowing, I can be confident that baby took a good amount. This would affect how much, if any, we supplemented with the NG tube. This would be different than if baby was at the breast for the same amount of time, but it was a mom who maybe didn't have as good of a supply, and she told me that when she pumps, she only gets 10 or 20 cc's every time. So we use this information. Your information and your knowledge counts. So what about bottles? It's important to know why the hospital is using certain bottles or nipples, or also if you're going to bottle feed at home, how do you choose a bottle that's right for your baby? Let's talk first about in the hospital. Many hospitals are now choosing Dr. Brown's bottles for their NICU. Why is that? In the retail world with full-term infants, many of you know Dr. Brown's bottles because they're anti-gas. There is a venting system that eliminates air from the bottles, which means less air gets to baby's tummy. But there are also many other benefits, especially to infants in the NICU. Dr. Brown's bottles are vacuum-free. What does this mean? Well, in other bottles, when babies drink, there's this buildup of pressure. This can actually make it harder to drink from the bottle. Think of it like you grab from the refrigerator a 2-liter bottle of pop and you start drinking. If you keep drinking continuously, you can tell that there's this buildup of pressure and you can feel it, and it gets harder. And then what happens? The bottle might actually collapse a little bit. So there's actually resistance in that bottle. It's almost like the liquid is being pulled in the other direction. The venting system in the Dr. Brown's bottle creates vacuum-free feeding, which eliminates that resistance in the bottle. So I want to show you just a minute about a video that helps explain this concept. Hospitals are finding that by eliminating this resistance, babies actually feed better because they aren't working hard against the bottle. Another reason that hospitals choose Dr. Brown bottles is that the nipple flow rate levels are very consistent. With some nipples, if you were to take 5 or 10 of the same type of nipple and test the flow rate, each time you can get a very different flow rate. Well, the Dr. Brown's nipples, especially those designed for NICU infants with the slower flow rates, are quality controlled and have some of the most consistent flow rates on the market. So when you use a Dr. Brown's slower flow preemie nipple, you know you're getting a consistent flow rate with each feeding. This consistency is so important at a time when our infants are learning so much about feeding and their feeding experience. A few other benefits of Dr. Brown's bottles is that they can preserve vitamins in breast milk. When air gets into the milk, as happens with other bottles without the venting system, this can cause something called oxidation. Studies have shown that this might reduce the amount of the vitamins that are present in the milk. Also, while it probably isn't the most important reason in the NICU, it can relieve symptoms of digestive disorders just by the fact that there's less air getting into the bottle. Now, premature infants often have immature digestive systems in general anyway, but this concept can still be a benefit. We have had several hospitals tell us that some of their babies with reflux have less reflux with the Dr. Brown's bottles. Finally, hospitals also choose Dr. Brown's because of the smooth transition to home. Dr. Brown's products can be used in the hospital and also at home, and they can be purchased everywhere, in stores and online. So what about when it's time to go home? If your hospital isn't using Dr. Brown's bottles, how do you choose which bottle to use when there are so many on the market? Of course, everyone may have their personal preference, and I always encourage that if a parent has a strong preference for a certain bottle, to bring it in and we can see how the baby feeds with it. But there are reasons to use the Dr. Brown's bottle at home as well as in the hospital. It isn't just for NICU babies, and there is a reason that it is the #1 bottle recommended by pediatricians. And why is that? Well, of course, all of the reasons I just mentioned hold true at home. Vacuum-free, zero resistance, consistency, the vitamins, but also due to the vacuum-free and air elimination, it does improve gas, which we did mention briefly. But in addition, I also wanted to mention here that I know many bottles on the market now say they're vented. Well, a vented bottle does not equal vacuum-free. So we've done some preliminary testing measuring that resistance that we talked about in the vacuum in commercial and hospital bottles. The Dr. Brown's bottles are the only bottles that have zero resistance or no vacuum, even when testing bottles that are vented by other means. Another reason is that Dr. Brown's is often the bottle recommended by lactation consultants when a mom is breastfeeding, but also needs to do some bottle feeding. This is always the big question. I'm a breastfeeding mom, so what bottle is most like breastfeeding? Well, that answer is really none, since breastfeeding is so unique. Nothing is exactly like breastfeeding when it comes to a bottle, but there are things that are important to look for. One thing we tell parents is that the shape of the latch on the bottle is important. Think about when a baby is breastfeeding. When they're breastfeeding, the baby needs to get a wide open latch and able to have effective breastfeeding. So with a bottle, you want to look for a bottle that the baby can achieve that open latch as well. You don't want a very, very small, narrow latch on the nipple. Also, most breastfeeding specialists recommend that, especially in the beginning, a breastfeeding baby, when drinking from a bottle, should use a slower flow nipple, such as the Dr. Brown's newborn or preemie nipples. This is true even of full-term infants when they switch between bottle and breast. Of course, every baby's different, and you need to make sure the flow rate is tolerated by your baby, but many breastfeeding specialists recommend Dr. Brown's as it contributes to a nice open latch and a slower flow when using our slower flow nipples. That brings us to #4, quality is important. This is an essential piece of cue-based feeding, but I think it needs its own point. It used to be that a good feeding was one where the baby finished the bottle and it didn't matter how he did it. The goal was to finish the feeding. This created times where we, parents and professionals, felt pressured to get the whole bottle in, and we sometimes didn't provide the best experience for infants in doing so. Remember, many of our NICU infants are immature. They are not pokey or lazy, but they're immature and their feeding is immature. Thankfully, NICUs are changing from a volume-driven culture to an infant-driven one. Although, of course, we eventually need the baby to take full feedings by mouth, but the quality, especially in the beginning, is just as important and maybe even more so. It isn't true that practice makes perfect, because bad practice makes for negative feeding experiences and may even cause learning poor skills, while good practice can lead to positive feeding experiences. And the goal of feeding in the beginning is to be positive and set the infant up for success. And finally, number 5, which relates to all the others, but is a phrase in its own, and we should just keep this phrase and remember it. Feeding is for life. After all, what is the goal? We all want feeding later on to look something like this: enjoyable, fun, social, positive, nutritious, safe. Experience matters. What happens in the NICU doesn't stay in the NICU. We are teaching about feeding for life. So ask yourself, what is my baby learning about feeding? I want to end with a true story about a baby I'll call Maggie. Maggie was born very sick and couldn't be held for quite some time in the NICU. But the nurses taught the parents that positive touch was important and that mom could help comfort Maggie. So mom placed her hand on Maggie's head and provided human comforting touch. Maggie improved and eventually was able to be held and then went home. Well, months later, as Maggie became an older infant, when she became upset, mom would put her hands on Maggie just like she did in the NICU in the same way. And this same touch comforted Maggie like no one else could. Her brain remembered and had formed a memory from this feeling. Her brain wired that this was a positive, comforting experience that mom provided. You, as your baby's parent, matter. You can make a difference. Thank you for listening. I think we have some times for questions if there are any.
So we do have some time for questions. I don't see a lot in the question box right now. I'll give you guys just a few minutes in case you have something that you might be already typing up. But just to wrap up, we are so thankful for you guys signing in today, learning more about nutrition in the NICU. We are so thankful for this partnership with Dr. Brown to give our families more support, as feeding both in the NICU and once you go home is something that's stressful, and we just want to learn as much as we can. Remember that after this webinar, the recording will be posted to the website, both ours and Dr. Brown's, along with a copy of the slides. We have one question that came in that says, what should parents do if they disagree with the way that their baby is being fed in the NICU?
That is a great question, right? I'm gonna, you know what, and again, so there's so many ways I think this could go, because it just depends on what your relationship is with your nurses and your therapists. But I think I'm gonna first let Summer start, because I think from her experience, she might be able to say what has worked for her, and then I can kind of piggyback off that. I think that a lot of it has to do with what your relationship is with your nurse or your doctor. But Summer, do you have anything that you want to start with? And then I can kind of, from the therapist perspective, I can add to it after you speak from the parent perspective. Okay, perfect. Yeah, so my biggest piece of advice on this would be to try to have an open conversation with your nurse and the doctor who primarily oversees your baby's care. As a parent, we're there to not only just love and support our kids, but we're there to advocate for them. And there's nothing wrong with bringing up a concern about whether you disagree with something, or at least just maybe try to figure out, like, what are your questions? Like, what is causing you to disagree with how your baby is being fed, and try to write those out into some questions that you can go to your care team and talk to them about, and just see what they say and just open up that dialogue with them. Yeah, I also just would love to add that I think that it's really helpful sometimes. I mean, I'm probably on the one side of it because I would want parents to come to me and say that, and sometimes not everyone is like that. It sounds from the question that maybe there, have been issues. So if the person hasn't felt comfortable in the past or hasn't been received well, to kind of maybe even take it from perspectives of asking questions like, well, what do you think about this? Or talk about the baby. So maybe say, I noticed my baby, when you are doing this, he's grimacing. What do you think? Or what do all those gulping? Talk about the behavior rather than, I don't think, and I'm not saying the parent would say this, right? But I don't think the way, or I don't like the way the baby's being fed, but to talk about it, go back to the behavior and the cues, because you can point out cues and no one can disagree with what's going on. So I think that is a great way to take it from the baby's perspective. Again, I always go back to, if the baby could talk, what would the baby say? And kind of relate the information that way.
I think that's all the questions that we have so far. I did want to mention that if you think of any questions as we kind of wrap up this day, you can reach out to Handlehold at info@handlehold.org. You can reach out to us on Facebook Messenger, whatever is easiest, but we'd like to send these questions back to Summer and to Lisa if you have any. So please just let us know. And thank you guys again for signing in today. And thank you, Lisa and the Dr. Brown medical team. And thank you, Summer, for sharing your perspective for other families to learn.
Thank you. It was a pleasure.